All right. And our very last speaker of the day, no pressure. Just gotta bring it home for us, Erin. I think we're all really excited about this because, definitely talking about therapy, but also talking about how we work as a team to provide that care for patients. And I don't know, I think it's something we all think about all the time, but doesn't always come up when we go to a conference. So I'm really excited to hear more about how we approach care as a multidisciplinary team. Erin Fahey-Harrison is going to be talking to us about this today. She is one of our inpatient and outpatient physician assistants and a senior instructor within our Blood Disorders and Cellular Therapy Center here at the University of Colorado at the Anschutz campus. Erin received her bachelor's degree from Vanderbilt University and completed her master's degree as a PA at Emory University. She first came to Colorado after being accepted to our hospital medicine APP fellowship and became interested in the blood cancer specialty during her time in that fellowship program, and has been an amazing member of our APP team, both inpatient and outpatient, for over 5 years. She serves on our BDC APP Leadership Council and is the co-director of our I think you're just the director, right? Yeah. Okay. I was like, wait, who's the co? Okay. Erin is our guru of our lymphoma disease state committee within our Blood Disorder Center. She's been instrumental in developing our lymphoma program, including our guidelines, education, and processes around the care of our lymphoma patients. So please join me in welcoming Erin to her talk.
Guys, bring it home. Wake up. We got a whirlwind tour of CLL right here. Yeah, it's kind of a different beast when you're giving someone else, another writer wrote the slides. And so, yeah, this is a whirlwind tour for sure. And I've enjoyed getting familiar with it all, putting it all together as a story. All right, so this guy, sorry, okay. All right, learning objectives today. Let's discuss the therapeutic approaches for treatment naive and relapse refractory CLL, SLL. We're going to summarize the differences in selectivity, binding, efficacy, and adverse event profiles of agents with a similar molecular target used in CLL. We're going to evaluate the evolving role of current and emergent therapeutics for CLL, describe how to manage treatment-related symptoms in patients with CLL, and outline multidisciplinary management plans for patients with CLL to optimize quality of care and address racial and age-related disparities. And as an APP myself, I have a bias for loving the multidisciplinary role of all this. So yeah, we'll get into that in a little bit. So CLL is a really important topic. As you can see, it's the second most common type of leukemia in the US. Of the 60,000 new cases of leukemia in 2003, you can see in our little pie chart that a third of them, I was going to try and use a cursor, but you can see the pie, a third of them are all CLL, which is actually astonishing to me. Over 4,000 deaths in 2023 related to CLL, and other little tidbits, CLL is more common in males, and average age of diagnosis is about 70, so it's in our older population. In general, you're going to think of CLL, especially new diagnoses, as kind of kind of sit and watch and wait in a lot of cases. And if they're asymptomatic and just hanging out there. So just a diagnosis of CLL doesn't mean kind of like an AML, what Allison was talking about, we need to get on therapy. We actually kind of do a watch and wait approach because there's really no literature that says the sooner we treat, the better the prognosis. So we actually don't affect people's lives with the treatment until there's really indications to do so. So in this international workshop of CLL, they've come up with a few guidelines on the indications for treatment. So first things are lymph nodes. So massive lymphadenopathy, over 10 centimeters, or just progressive, like you saw them 3 months ago and they look normal, and then you saw them and they were like this. Or if these lymph nodes are becoming symptomatic, so causing problems to the patient. This says liver and spleen size. I think most of are looking at spleen size here. But yeah, massive splenomegaly that extends over 6 centimeters below the costal margin. Constitutional symptoms. So that's our weight loss. loss of over 10% in less than 6 months unintentionally. Fevers, fatigue is a big kind of constitutional symptom that we'll include in the CLL realm. And then like recurrent infections, night sweats, of course. And then with recurrent infections, we're also thinking about recurrent fevers as well, which could be infection or the disease causing it. Circulating lymphocytes does play into this when we're not talking about absolute number, but when it's progressing, when the lymphocyte count is really progressing. So doubling in time, doubling in less than 6 months, or I think greater than 50% in about 2 months. So we'll start thinking about therapy. And then as we start to see that white count get even more higher, we start to become more symptomatic. We can also start to see some bone marrow failure. So our bone marrow can only do so much, and when it's being told by this monster cancer to make all of these cells that it shouldn't be making, it's unfortunately spending all of its resources making these CLL cells instead of making our platelets and our hemoglobin. So you'll start to see worsening thrombocytopenia or anemia. And so kind of numbers to look at there are platelets that are dropping less than 100, hemoglobin dropping less than 10. And so, yeah, just progressive signs of marrow failure. And then we can have extranodal disease in rare cases that can also become symptomatic. So these are the things you're looking at in your patients when you start to think, okay, now can we provide treatments that are actually going to make symptoms better? As opposed to when people are asymptomatic, you don't want to throw in a drug that could have some side effects that are worse than the disease itself. So these are the kind of the things you're thinking about. Then we have the CLL IPI score. We, with this score, are predicting the time to first treatment. As I said, we don't usually treat these people off the bat unless they're very symptomatic. But it is nice to be able to give patients this idea of what the next couple of years of their lives might look like. And so on diagnosis, kind of talk about like, when might it be time to treat you? And so this is a kind of a score that we use to kind of say, when do we think you'll need treatment? Is it in like 1 year or is it in like 5 years? And so the biggest kind of changing factor here, as you can see, are these mutations. Deletion 17p and TP53 mutation are adverse risk mutations that can occur. And if either one of those are positive, is going to give you 4 points. Unmutated IGHV is going to give you 2 points. IGHV is a gene that basically is inactivated in our younger cells. And after our cells go through these somatic hypermutations of maturity that are normal, it mutates to active. And so unmutated indicates that we are dealing with a more immature cell that's giving rise to CLL. As opposed to mutated indicates a more mature cell giving rise to the CLL. And I thought it was funny reading about this. It equated it to like if an infant baby comes out of the womb with like fungal toenails, you're like, oh, what has happened? But like if a 70-year-old male walks into your office with a fungal toenails, you're like, normal. So in the same way, if a young cell has CLL, we're a little more concerned than if an old cell has CLL. I thought that was a good way to put it. So anyways, so the unmutated IGHV is actually the worser one, which I feel like can get a little confusing. Serum beta-2 microglobulin is something that we're getting in CLL and all of our B-cell lymphomas, which has prognostic information. And then our Rye staging matters for this CLL IPI score. Rye staging it goes from 0 to 4. So you can see in this scoring, a Rye stage of 1 to 4 is what gets you a point. The Rye staging in CLL is kind of 0 is just a high white count. 1 is a white count with lymph nodes. 2 is a white count with a big spleen. 3 is a white count with some marrow failure. 4 is all the above. It's kind of stepwise like that. So a stage of 1 to 4 is what's going to get you a point here, and then an age over 65 will get you a point. And you can see in this chart over here, you're looking at how these numbers from low risk to high risk, the high risk time to first treatment is this line here. So you see this high risk, more percentage of the patients are needing treatment within these first 2 years than these low risk or intermediate risk patients. So this doesn't actually make any treatment decisions for you, but it's certainly nice to try and tell your patients what the next couple of years of their lives will look like. Um, This is kind of like NCCN guidelines of our treatment regimens, what's recommended. So first we have this newly diagnosed CLL patient. We're going to assess them for the side effects we talked about with the international working group. And then the biggest thing right now that's deciding treatment is not only a conversation with your patients, but this TP53 mutation. Is it normal or aberrant? And you'll see that the options here are the same, but the preferred is a little different. So if they have a normal TP53 mutation, then we're looking at we can either offer a fixed duration of venetoclax obinutuzumab versus indefinite therapy with a covalent BTK inhibitor, so ibrutinib or acalabrutinib or zanubrutinib. If you have an aberrant or mutated TP53, these patients do worse. And right now, the preferred is the covalent BTK inhibitors. We can offer them venetoclax obinutuzumab, but we prefer at this point with a mutated TP53 to do indefinite treatment with the covalent BTK inhibitors. You'll see in the aberrant TP53 mutation, this is kind of where testing for MRD comes into play, because what they'll do with these higher risk patients, if they do choose the definite therapy, the fixed duration therapy, is they might decide how long to do the venetoclax based on their MRD positivity. So then we get to second line treatment. So now we've either progressed through or we're intolerant of our first line therapy. And so this one's not very hard. If you tried venetoclax obinutuzumab first, then you should try a covalent BTKI. So here we are here. If you tried a covalent BTKI first, then you should probably try a venetoclax with a monoclonal CD20 monoclonal antibody. You will see here that there's also the option of this non-covalent BTKI and BTK inhibitor, pirtobrutinib, which we'll get into in just a little bit. Super exciting. I will throw in a little clinical tidbit here. The studies that looked at venetoclax and rituximab, or in the second line relapse refractory setting, did look at Ven-Ritux. I will say in our clinic, we're generally going towards the obinutuzumab here. I would just say for all intents and purposes, this is venetoclax with a CD20 monoclonal antibody. But yeah, this here says rituximab mostly because that's how it was studied. But I think most people are kind of going towards the idea that obinutuzumab does have better progression-free survival here. So you can see here that our options here are venetoclax, CD20 monoclonal antibody, our covalent BTK inhibitors versus our non-covalent BTK inhibitors. And so you're kind of mishmashing with those depending on what they've progressed through. So now we've progressed through maybe 1 to 2 of those first ones I mentioned, and so now we're looking for more things. So now we're looking at going to this non-covalent BTK inhibitor, pirtobrutinib. The PI3K inhibitors are still mentioned here, like idelalisib. We really aren't using those right now in the realm of CLL because of the side effect profile. So I don't mention them a ton in this talk. And then we can also go to CAR T cell therapy or to allogeneic stem cell transplant. So as you could tell in a lot of what I was just talking about with the therapy options, there are some choices here, which honestly, some patients actually truly hate. They're like, why are you asking me? I don't know. But some people love. We have some choices here. And so this is a slide about a clinical trial, a web-based survey on what patients prioritize when they're getting to have some say-so in their therapy. And I think kind of no surprise, number one is sort of no surprise to me, at least, that, increasing their chance of progression-free survival at 2 years from 70 to 90% was pretty important to patients. Okay, lengthening their progression-free survival. Awesome. I thought interestingly, number 2 was importance to patients when they're choosing their regimen, was confirming results with MRD testing. And the way this was presented to patients was, do you want to be able to tell if you're in a remission versus a deep remission versus maybe remission just from a blood test? And so that's how that, so is it an easy, non-invasive way to say, how deep is this remission? People really liked that idea. They liked the idea of a daily oral drug versus an IV infusion was the third priority. And then the fourth priority was the fixed duration treatment. People liked the idea of like, let's do this for a year versus like you're on this forever. So, ooh, this one's flipped. Okay, not your problem, just mine. So the mutational landscape of CLL drives disease progression and therapeutic resistance. The science of CLL is super cool, talking about enzymes and kinases again. I recently have only been talking about enzymes because my dog is peeing everywhere, so we're using enzymatic cleaner, and I'm hoping that that gets the smell away. But this feels more appropriate here, so now we're still talking about enzymes. But so this is kind of a slide sort of showing you the BCL receptor signaling pathway and kind of the mutations that can be involved with it, but then also just the kinases that we can try and target to treat this disease. So the key mutated genes in CLL influence disease progression and treatment response. So as I've mentioned, TP53 is a big one here. Deletion 17p is a big one here. And then of course your IGHV mutation, unmutated versus mutated, like fungal nails in a baby versus in a grown-up. Next thing is sort of cool. So, we'll get into it. But next thing is looking at the fact that in any of these locations, if you get a mutation in something that we're targeting, does our targeted therapy work as well? The answer, unfortunately, is no. So BTK and PLCG2 is phospholipase C gamma. So BTK is Bruton's tyrosine kinase. It is one enzyme in the step of BCL signaling. And so the B cell gets an antigen on its outer proteins and then sends all these signals to the cell that basically are going to help it proliferate. And so Bruton's tyrosine kinase is one step in that process that we've figured out a way to block with a Bruton's tyrosine kinase inhibitor. If the residue that we're targeting with that inhibitor is mutated, the drug no longer binds as well, and then we're stuck with a B cell that is actually still getting to do its signaling and potentially proliferating. Phospholipase C gamma is like the next step in that sequence of B cell signaling. And so when that's mutated, it can be a gain of function mutation that can actually allow for B cell signaling independent of BTK. So mutations in either one of those enzymes allow for progression through ibrutinib or its cousins or siblings of sorts, its other covalent BTK inhibitors. BCL2, an anti-apoptotic enzyme. So these are a lot of double negatives, very confusing. It's an anti-apoptotic. So if we have a lot of them, we're all anti-apoptotic, which means our cells can't go through cell death. We target these BCL2 proteins with venetoclax so that the BCL2 stops telling these cells to not die. If BCL2 mutates so that venetoclax can't bind to it, unfortunately, we might progress through venetoclax. Let's see, MRD. MRD is kind of a fancy new thing in the world of CLL. We're calling it measurable residual disease, or I kind of grew up in this world with minimal residual disease. We're now calling it measurable residual disease. And that's basically because at every institute with different labs, who knows how low can you go as far as measuring it. So now we're calling it measurable residual disease. I think what's been found with measurable residual disease in this disease is that it is very, very telling of progression-free survival if we can get you to unmeasurable MRD. It's being used in clinical trials as a primary endpoint. It's also being used to help compare therapeutic strategies. So do we get, undetectable MRD or not? I would say the coolest part about it moving into our clinical trial space is that it's actually, it's making it faster for us to get drugs through the FDA because now we don't have to wait on like progression-free survivals to extend beyond 3 or 5 years. If at the 1 year mark, we're proving that 60% of patients are undetected at MRD, and we already know that undetected MRD gives us a lot longer PFS, then the FDA is like, cool, good data. We can get that through as opposed to like at the 5 year mark being able to prove it. So it's actually helping us get some of these drugs a little bit sooner than we actually would through the FDA. It's also being used in clinical practice, depending on where you work and depending on who your physicians are. How it can be used in clinical practice is that as a prognostic tool. Nice to be able to tell your patients that if you get undetectable MRD, like that's really great. Your progression-free survival is definitely higher. It can also be used as a therapeutic goal. Should we just have them on venetoclax until we get undetectable MRD? It can also help trigger early intervention. We'll talk a little later about how CAR T cell patients do a lot better with a lower burden of disease. So if they start to relapse just with some MRD and we go straight to CAR T, that person might do better than if we let the disease get a little bit more detectable, and so that the CAR T might not work as well if it's a little bit too far gone. Cool. So the evolution of the treatment landscape of CLL, I've kind of been through this slide a little bit, although I do really like this slide and the pictures. So this is our B cell here in the middle. And if you just study the B cell, you'll understand how we treat CLL. It's super cool. So there are these, when you're looking at the surface protein, CD20 is universally expressed on B cells. And so there are these monoclonal antibodies, most notably obinutuzumab and rituximab, that we can target to get rid of these B cells. There is also a CD19 antigen off the surface of these cells, which, as we all know, is really important for the CAR T space right now. We're targeting CD19 in the CAR T space. Then over here, this isn't quite as relevant in CLL, but I still think it's cool, is the CD20, CD3. CD3 is on T cells. So this is actually how the bispecific T cell engagers work. One arm is targeting a B cell, one arm is targeting a T cell, and if we can make these cells hug, then the T cell eats the B cell. Doesn't sound great for a friendship, but and then up here we have our B cell receptor, which ultimately is how like our CLL cells proliferate, is in this B cell receptor pathway. And so you can see here that one of the areas that we're targeting is this BTK, so trying to inhibit that with our covalent and non-covalent BTK inhibitors. And then these PI3K inhibitors, phosphoinositol 3 kinase inhibitors, are inhibiting parts of the same pathway. So let's talk about our Bruton's tyrosine kinase inhibitors, covalent to non-covalent. So ibrutinib is kind of our original OG here, and it binds to this residue C481. Same with acalabrutinib and zanubrutinib. Acalabrutinib and zanubrutinib are second generation, so they have a little bit more specific binding here, which is helpful because it minimizes off-site targeting, so less side effects. But it still binds like to the same residue on the kinase. The pirtobrutinib, which has a non-covalent bond, which actually the type of bond doesn't seem to matter. I really tried to figure this out, but the biggest important part is that pirtobrutinib binds to a different part of the BTK. It binds to an ATP pocket that's distant from the C481 81. This is a typo, sorry. Residue. So down here we can look at how if a patient again has a C481S mutation, so a mutation at the site of binding for the covalent BTK inhibitors, then these patients are going to progress through these drugs. And so the cool part about that is that pirtobrutinib does not bind to this same residue. So having this mutation means that pirtobrutinib could still be effective, and that's also proven in clinical trials as well. see. Yeah, cool. All right, here's a whirlwind tour of all the studies that got us to like those NCCN guidelines and things like that. So we start out with our first BTK inhibitor, this ibrutinib, and this is the first line in first line CLL. And we're comparing ibrutinib to chlorambucil. Chlorambucil is kind of like your old school alkylating agent that just stops or it damages DNA, so it stops cells from replicating. So we're looking at a really targeted agent to the BTK kinase versus a kind of broad chemotherapy. And I think we can all guess what happens here. Our progression-free survival at 7 years on ibrutinib is 59% versus chlorambucil is 9%. So ibrutinib here is this nice purple arm that, yeah, even out to 7 years has, almost 2/3 of people still living without their disease. And then similarly, to follow that, our overall survival at 7 years is actually almost 80% on ibrutinib. So very, very cool. Also, ibrutinib has some side effects that we don't love, but honestly, when it comes to this amount of progression-free survival and overall survival, we have pretty manageable side effects, I would say. So we see cardiac events, neutropenia, infection, hypertension. We'll get into a little bit more about the side effects a little later as we compare them to their brother and sister, zanubrutinib and acalabrutinib. So here acalabrutinib comes into the mix. This is a second generation BTK inhibitor, more selective. So again, avoiding the off-site target, so less side effects. Let's see, we've randomized these patients to acalabrutinib plus a CD20 monoclonal antibody versus acalabrutinib monotherapy by itself versus obinutuzumab and chlorambucil. So again, chlorambucil, just like your alkylating agent. Super interesting here is that, these top two lines are the two arms that included acalabrutinib. So acala plus obinutuzumab, progression-free survival was 90% at 30 months. Actually, I should go up here and all these had multiple, they update their data every year or so. So lots of papers to get through. And so these top two, again, are the ones that include acalabrutinib. So the progression-free survival at 48 months is 87% up in this purple line and 78% in the green line, as opposed to our non-acala regimen that had chlorambucil and obinutuzumab. Progression-free survival at the 2-year mark is only 25%. So really pretty impressive here to say that our BTK inhibitors are doing something really great for us, because even the acala group alone was quite a bit better. Then we have zanubrutinib, another selective non-covalent next generation BTK inhibitor up there kind of in the same class of ibrutinib and acalabrutinib. And in this, we're still looking at treatment naive, untreated CLL. So in this trial, we're comparing zanubrutinib with BR. BR, bendamustine rituximab, is kind of a chemoimmunotherapy that used to be fairly standard up with FCR in regards to treating CLL. And so, yeah, we're doing a zanubrutinib versus our chemoimmunotherapy, and just showing that zanubrutinib, our next generation BTK inhibitor, has a significant improvement in progression-free survival. So the 24-month mark over here, we're looking at a progression-free survival of 85% versus about 70% in the chemoimmunotherapy arm. And then the zanubrutinib was also a bit safer. It has I would say the biggest difference with the zanubrutinib and the BR as far as side effect profile was the zanubrutinib causes a lot less neutropenia, grade 3 and above neutropenia. So 11% in the zanubrutinib arm versus 50% in the BR arm. As far as AFib, significant bleeding, hypertension, those were all fairly comparable in the two arms, zanubrutinib versus BR. So again, more data to say that these targeted therapies are really, really improving our progression-free survival and are fairly safe to do. So then we kind of delve into the relapse refractory side of things. So we've already tried something and they've either didn't tolerate it or they progressed through. And so now we're looking at patients that have had at least one other line of therapy. So this is ibrutinib, how ibrutinib compares to a CD20 monoclonal antibody in the relapse refractory setting. So ibrutinib versus ofatumumab, for intents and purposes, CD20 monoclonal antibody. And you can see that it's not a surprise that the progression-free survival for the ibrutinib arm is 44, a median of 44 months versus 8 months in the versus a median survival in the ofatumumab arm is only 8 months. I think the bigger important part of this particular study is that this also remained true in our high-risk group. So you can see that these included people with 17p deletion and TP53 mutation. And the median progression-free survival on the ibrutinib was 44 months for both of those subsets, so average risk and high-risk groups. And the OFA was also about the same at 8 months, median progression-free survival. So again, showing that ibrutinib, even in the second line for relapse refractory, is a great option. So then we get to the ELEVATE trial, which is a non-inferiority trial for acalabrutinib. Acalabrutinib, basically in this trial shows that it has a good progression-free survival along with ibrutinib, but has fewer cardiac side effects. So that's exactly what this slide shows. So our median progression-free survival was 38 months for both arms. So what's that, like 3 to 4 years, which is awesome. And then when we're looking at the cardiac event profile, so here's the cumulative rates of cardiac events, and this is just a longer follow-up here. But you can see that the green arm is ibrutinib, the purple arm is acalabrutinib. So ibrutinib does have higher rates of cardiac events, which generally they're talking about AFib flutter or hypertension. So I think, so the AFib flutter rates for acalabrutinib were 9% as opposed to ibrutinib at 16%. So, ibrutinib has about a 30% higher chance of causing AFib flutter in your patients than the acalabrutinib. Zanubrutinib is actually acalabrutinib was non-inferior to ibrutinib. Here in the Alpine trial, we're looking at some data that is showing that zanubrutinib, it's another covalent BTK inhibitor, actually is superior to ibrutinib in relapse refractory CLL and has fewer cardiac side effects. So that's cool. So we're looking here at, the purple arm being, my cursor turned red. That's cool. Our purple arm being ibrutinib and our green arm being zanubrutinib. And looking at, am I saying that right? Nope, I was backwards. Purple being zanubrutinib, green being ibrutinib, because this is, looking at progression-free survival. So at 24 months, zanubrutinib had a progression-free survival of 78%. So, that's 8 out of 10 patients still alive at the 24-month mark in the relapse refractory setting, which is pretty cool, versus ibrutinib was only 65%. So that's listed here at the 24-month mark. So showing that zanubrutinib does have a significantly superior progression-free survival than ibrutinib. And then they also looked at the cardiac event profiles, which are showing that ibrutinib definitely has a bit higher cardiac events than the zanubrutinib. Most notably, at least in my head, is that the AFib rate for the zanubrutinib was only 5% of patients versus in the ibrutinib arm, 13% of patients. So in this study, we're looking at ibrutinib has about a 60% increased risk of AFib than the zanubrutinib. So the zanubrutinib quite a bit safer from a cardiac perspective. Then we get to pirtobrutinib, which again, still is inhibiting your Bruton's tyrosine kinase, but just in at a different residue, far from that C481 residue. So that if you're mutated, shouldn't matter, which is super cool. So this is the Bruin study. We're looking at pirtobrutinib in the relapse refractory setting. I think everyone's a little bit afraid of studying it in the frontline setting for this moment, because the others do so well. So we have data in this relapse refractory setting. And let's see. So this was tried in patients with a median of 3 prior lines of therapy, and the overall response rate was 73%. And the median progression-free survival was 19 months. So these are people that maybe have had it 3 therapies, that were extending their progression-free survival like almost 2 years, with this brand new agent. So that's really quite cool. And I will say, the grade 3 or higher adverse events were very, very low. Other side effects we're looking at were fatigue, diarrhea, bruising, neutropenia. Very little, very severe side effects with this particular drug. And this overall response rate at 73% was consistent across the people that had the mutation at C481 that causes them to be resistant to the other covalent BTKIs. For the people with no mutation or with a mutation had about the same overall response rate to pirtobrutinib. So super cool data for people that have progressed through those agents. Again, we were trying to kind of highlight in this talk, getting these therapies out to the community and disparities in health. And so I think talking about the side effects is a really important part of these. It's really easy to take a pill every day, when you say that, but it's easier said than done. So looking at these side effects and thinking about how you might manage them for these patients is really important. You can see that ibrutinib, our AFib rate is 16%. It gets a lot lower with our next generation drugs. So generally at this point, we're using acalabrutinib or zanubrutinib, and then pirtobrutinib, of course, in the relapse refractory setting. So let's go over to thinking about what we are going to do for AFib. So, if this patient is being well controlled on their BTK inhibitor and they have rate controlled, stable AFib, you might not touch it. You might put them on some stroke prevention, so some anticoagulation, and have them see a cardiologist and kind of make sure it's not going anywhere. That also easier said than done, right? These drugs have bleeding risks. So now we're also on a blood thinner. So we've got to think about that. So just things to think about when you're causing AFib in these patients. You can also try and change the agent, try to change to a different covalent BTK and see if that one, causes the AFib as well. So it's worth changing meds in the same category, or thinking about the risk benefit of being on anticoagulation and having rate controlled AFib. Management of bleeding is pretty important. These drugs can cause major bleeding. And so having a good rule and regulation and education around holding these drugs for different procedures. So our patients, I do a lot of CLL surveillance while they're on these drugs. And every single time I say, to tell us if you have any medical thing coming up. I want to know if you're getting Botox or getting some of your bowel removed. Like, I want to know it all, and then I'll tell you what I recommend here. And so, for low risk bleeding, things like dental work and things, we recommend like 3 days off, 3 before and after off of the drug. And then for more invasive things, we might recommend 7 to 10 days before and after the procedure to hold the drug. So I think a big part of this is education, so the patient knows to call you if they have anything that's going to come up. Arthralgias and headaches are a real thing. I definitely see these in our patients. I will say in both cases, I see these patients, they resolve. So that's cool. Like, I see this a lot in the first 3 to 4 months of therapy, and then it actually slowly gets better. I will say the nice part about the headaches is it's usually a pretty quick fix. It's like, just make sure you get your caffeine first thing in the morning, and people have a pretty good outcome from that. For the arthralgias, you just want to make sure you're not recommending like too much like around the clock NSAIDs because of the risk of bleeding with these drugs. You wouldn't want them on around the clock ibuprofen, just something to think about when you're trying to treat their arthralgias. The hypertension involved with BTK inhibitors, I also have seen clinically. I will say I haven't really had to treat it. It's just like something to note. But it's not like it's getting out of control where I've had to treat it. But I mean, I think safe to treat it if you need to, especially if it's controlling their CLL. Cool. So now we get into venetoclax. So venetoclax, you've all heard about our BCL2 inhibitor. BCL2 is a protein in cells that is, again, anti-apoptotic, so disallowing the cell from going through programmed cell death. And in a lot of blood cancers, including CLL, BCL2 is upregulated, so there's too much of it. So these cells have a survival benefit because they're being told by all these kinases that shouldn't be there not to kill themselves. So venetoclax is blocking these extra BCL2, so taking away that survival benefit from these cells so that they can't proliferate. So now, yeah, we're going to throw in venetoclax into the mix, and we're studying it here in the first-line setting, venetoclax plus a CD20 monoclonal antibody, obinutuzumab, we had pretty good results here. This is when we also are going to pull into that piece of MRD positivity or negativity. So venetoclax plus obinutuzumab significantly improved progression-free survival over chlorambucil plus obinutuzumab, with a median follow-up of 40 months. And it also has a pretty high rate of getting people to undetectable MRD, which we automatically knows increases their progression-free survival quite a bit. These two graphs over here are basically showing you this green area is undetectable MRD. So you can see that how much more green in this area than in over here. So the chlorambucil and obinutuzumab group has some people that got to MRD negativity, but you can see how many people get to MRD negativity with the venetoclax obin. So that's super cool results there. Next study we're looking at is ibrutinib venetoclax versus chlorambucil obinutuzumab. Ibrutinib venetoclax resulted in significantly longer progression-free survival as compared to chlorambucil and obinutuzumab. So ad nauseum showing you that chlorambucil needs to go and obin should stick around, but with the right other drugs. So you can see here, this is the MRD. This is still looking at MRD category. And so the people getting into an MRD negative remission are in the purple here for the ibrutinib venetoclax arm versus the chlorambucil obinutuzumab arm. Again, kind of showing how MRD can get these things up to market quicker because this primary endpoint was looking at the MRD as opposed to like the progression-free survival, like waiting until years and years out. All right, and then we're looking at, this is a cool study. I mean, it's a lot to take in. It's busy. But this is a cool study because it actually looks at venetoclax in a lot of different combinations. So I think we all can go ahead and swallow that this arm, chemoimmunotherapy arm, which is FCR or BR, not a thing we're doing anymore. We have better things. So the other three arms are interesting. So we have venetoclax and rituximab. We have venetoclax and obinutuzumab. So in that way, we're looking at, is venetoclax do better with ritux or obin? And then we're looking at venetoclax, obin, and ibrutinib. So lots of drugs going on over here. What this study is showing is that venetoclax plus obin, whether or not ibrutinib was involved, had an improved progression-free survival. And so that's really cool to see. So over venetoclax rituximab, so the progression-free survival at 3 years for the ones that include ven-obin are 90% and 87%, versus ven-rituximab with 80%. So I know, again, hard to take in, especially late in the day, but what this is showing is that ven-obin does better than ven-ritux. So that's cool. And then let's see, there's one more. Oh, no, that was pretty much it. Oh, and the other takeaway from this particular study is that you should have venetoclax involved. Yeah. So that's cool. So this is looking at it in the relapse refractory setting. So venetoclax plus rituximab. The Murano study uses rituximab instead of Oben, which is why the NCCN guidelines say that. But again, I think in a lot of places are doing the Oben with the venetoclax. But again, this is the Murano study showing that in the relapse refractory setting, your venetoclax rituximab is better than BR. Venetoclax rituximab progression-free survival at 2 years was over 80% versus 36% with BR. So in the relapse refractory setting, we also think that venetoclax with a CD20 monoclonal antibody is doing a great job. Tumor lysis syndrome. You, thank goodness, heard all about this from Caroline, which is great. Venetoclax can cause this. We're just doing such a good job of killing off these cancer cells that the cells open up and all the stuff from in them gets out into the blood. And even if you have really functional kidneys, that amount of toxins that even healthy kidneys can't handle. And so we need to be a little bit careful with venetoclax. So you will see us mitigate venetoclax in 2 ways. We will usually pre-treat with the CD20 monoclonal antibody. So they'll get a month or a cycle of the CD20 monoclonal antibody prior to initiating the venetoclax. And the venetoclax is actually dose escalated over 5 weeks, starting at 20 milligrams. So it sounds like very baby when you're thinking about AML. But there's a lot more TLS and CLL. Yeah, we're in our particular setting, we actually, for their first 2 dose escalations, they come in the morning. Their labs look good. They take their pill. They come back at 3 p.m. and get more labs. And we say, great, we get some fluids. Next morning, they come back again. And if their labs look good, we tell them to take their pill and keep doing it. So we actually have them have sort of almost 3 Q12 lab checks as an outpatient with 2 liters of fluids in and around those 3 checks to mitigate the tumor lysis syndrome, as well as, like I already said, giving them the CD20 monoclonal antibody first to sort of debulk them. Obinutuzumab is associated. Biggest side effects here are the infusion-related reactions. That's sort of old news, right? I mean, rituximab too. We get, slow down the infusion, give the Benadryl, give the Pepcid, toss them some Claritin, see how that does. And we get them their dose in most cases. And if we have to, we'll admit them to the hospital if they haven't quite finished their dose and give it to them nice and slowly. Same thing with Oben. It has a little bit of higher reaction rates, but kind of, looked at the same way by our staff. I will say the one thing I've noticed with obinutuzumab to keep in mind, like in the community setting, is I do see a little bit more count drop in that first cycle. So with Oben, yeah, you want to kind of keep an eye on the platelets, especially that's sort of anecdotally in the clinic I've been in, but I do see some platelet drop. So kind of worth kind of monitoring and discussing with your colleagues if you need to. A little bit more count drop with the obinutuzumab. Covalent BTK. Wait a minute, we're kind of running out of time. Let's see where we should go with this. Covalent BTKs versus BCL2 inhibitors. So, this is why, the patients have a choice here. That's why I showed you that slide a little while ago with the survey of what patients are how they make their decisions with anti-cancer therapy. And so we've kind of been through what they prioritize. And so sometimes unless they have a TP53 mutation, I think, our physicians sort of let them choose. Because, the outcomes are sort of similar as far as starting with a covalent BTK inhibitor versus like a venetoclax-based regimen. And so, you can look at the pros and cons here. BTK inhibitors have a little bit more of that cardiovascular risk, hypertension and AFib. It has a little bit more like myalgias, headaches, things like that. The venetoclax has a lot of the TLS, but we have such good, routes of mitigation for that it's not something I'm always hugely upset about when I'm talking to the patients because we do a really good job preventing it. And then, if you start with a BTK inhibitor, you can go to venetoclax after. If you start with venetoclax, you can then go, it doesn't really matter the sequencing. You aren't affecting how the other one's going to work. And then after both, you can go to cellular therapies like CAR T or allogeneic stem cell transplant. So it's a nice thing. In some cases, you can sort of talk with the patients and see what's best for them. So then we go to CAR T cell therapy. Super cool. So this is our CD19 cell-directed CAR T cell therapy, lyso-cel, kind of the first one used in the CLL setting. The CR rates for lyso-cel in this initial study were only 18%, which sounds low, but I will say that that these people, so 1 in 5 people that get into that respond, actually have a really deep response, have a undetected MRD and do well for a decently long time, even though 18% might not sound like a rate you're loving. But 1 in 5, I'd probably try it. And it's a pretty long response. So then we can go to kind of its brother. The JCAR014 has a different transmembrane domain. I just had to have our guru, Heather Knowles, help me with understand this, but they're pretty genetically similar, but they have a few different constructs in how it's manufactured. And so with this particular construct, actually the overall response rate is now up to 70% at the day 28 bone marrow biopsy. And the MRD, let's go. The MRD, undetectable MRD rates are 62%. Yeah. So yeah, CAR T is, like in a lot of the other talks today, looking really great too. So better overall responses, and then getting to undetectable MRD, which we know improves our progression-free survival. I think one big thing to note in this trial is to know that the less the disease, the better the patients do. And so getting them, promptly to your academic center for CAR T therapy is important, and that's also where MRD can come in. If you see an undetectable MRD for a couple years and then it's detectable, it's like, okay, let's go right to CAR T and not wait for things to get crazy. CAR T can cause cytokine release syndrome. One of my amazing colleagues described this beautifully. I think it might have been Kelly Sidor. So I won't go through that again right now. Fever, hypotension, hypoxia. Treat it if you need to. People in the community, we should probably treat them or teach them better. But unfortunately, I don't think I have time right now. So we can also go to allogeneic stem cell transplant with CLL. It's not that common, and I think some of my colleagues are gonna be like, "What? We really do?" Because I haven't seen it that much in our clinic, although we have one right now that's going through it for CLL. These transplants can also give us long-lasting remissions in 30 to 50% of heavily pretreated CLL patients. The 5-year overall survival for CLL patients is 45%, which is really pretty good. I mean, I think it wasn't as in favor for a while because of all of the risk factors that go into allogeneic stem cell transplant. People die of infections, they get really bad GVHD. But we do Carrie beautifully illustrated, we're doing a really good job of mitigating the big risks of allogeneic stem cell transplant. And so as we, are weighing our risk benefits, our risk is getting a little lower because we do a better job preventing a lot of things. We'll go to this slide and say, SOS, yes, we see it. We do a great job preventing it. Mucositis, we have dietitians that love to push tubes down people's noses and we get them fed. And then we're talking through graft versus host disease, tons of new drugs coming out for that. Also new drugs to prevent it. So your calcineurin inhibitors, your mycophenolate, your post-transplant Cytoxan, like Carrie was talking about. So the idea of an allogeneic stem cell transplant in a disease like CLL is becoming, I actually think it's a little bit more in favor than it was because we're doing a decent job mitigating the bad side effects of it. So we sort of have a better chance of improving the patient's life as opposed to making it worse. Yeah. Let's see. You can't talk enough about the benefit of multidisciplinary care. It starts with the primary care physician seeing that something is wrong. Then we have to get a bone marrow biopsy or send the blood for flow or NGS at labs. Pathologists need to look at all the biopsies under the microscope. We need a hematologist involved. We need a radiologist involved a lot. And then we go to our RN intake team. Then we go to our MDs that are like looking at all this data all day to know what's the next best thing for this patient. Then we have our PAs and NPs that are ensuring that, our patients are well educated in the therapies they're about to start, the side effects they might have, and also screening for the side effects at each and every office visit. We have 3 different RN teams. So we have like care coordinators that are RNs that are a huge part of it. We have our BIC and infusion RNs, and then we have our triage RNs that are kind of doing huge parts of this care and making, helping to make our outcomes better. Our pharmacists play a huge role in not only education, but looking at our drug interactions, our dosing, things like that. It takes a huge multidisciplinary team that does so much. And I mean, the APPs, obviously. Really, really important to have that big full team, which a lot of places don't have the beauty of having, but it is pretty important to allow these patients to do the best they can. This is more about the multidisciplinary interventions that are really important. We were talking about here about, like we said earlier, it's easier said than done, take this pill every day. But it also takes this whole other team. People I didn't mention in the last slide are like the social workers. Can the patients get rides to your clinic? Can they pick up their drugs at the pharmacy? Can they afford their drugs? Are they educated on the side effects? So like when they get a headache, they don't just stop the drug. They have a sip of coffee, it'll go away. So I think, the education around it, having a 24-hour triage line that they can call and say, nope, keep taking the drug. Here's what I want you to do to get rid of that knee pain or whatever it is. So super important to have someone they can call immediately so they don't just like stop their drug and say, this is stupid, I'm not going to do this anymore. So tons and tons of people involved. This is a important slide to note that, the racial disparities persist, even in the era of like easy oral drugs. So this data is, looking at outcomes for Black people versus white people. And on the left is before 2014, which was when our BTK inhibitors came out, versus after. And it's not that much better. The Black race is still consistently has a poorer outcome, like overall survival than white race. So it's like an independent risk factor for worse overall survival. So just something to keep in mind. This last slide is sort of just kind of mentioning that clinical trials aren't always very reasonable options for patients. There's a lot of structural and clinical barriers that make participation in them largely impossible. This is a study that looked at 13 trials across some academic and some community centers, and basically only it's in about 3 out of 4 cancer patients, the clinical trials weren't accessible to the patient for various reasons. So lots of things to think about from the clinical trial perspective, allowing this to more benefit like larger portions of our population. Is everybody awake? Oh my gosh, you don't have to answer that. So CLL is the second most common type of leukemia in the US. CLL treatment decisions of newly diagnosed patients is actually largely determined by TP53 mutation and patient preference. If TP53 mutation is not present, it's a lot of patient preference. Mutations in Bruton's tyrosine kinase and in PLCG2 can actually be treated because that's a common resistance pattern. And so there are some things we can do to still treat those patients that are becoming resistant. MRD is a biomarker that we're starting to use in CLL that is mostly affecting the clinical trial space right now. And I think will start impacting clinical practice as well in the coming years. MRD negative status is definitely shown in several places to have a better progression-free survival. Newer BTK inhibitors like acalabrutinib and zanubrutinib do have a better side effect profile from a cardiovascular risk perspective. The non-covalent BTK inhibitors like pirtobrutinib have really good overall response data in both patients with BTK mutations and without. Fixed duration therapy with venetoclax and obinutuzumab in the frontline setting can lead to undetectable MRD and prolong the progression-free survival. And then CAR T cell therapies have really promising responses in the relapse refractory setting, although have some side effects we need to, sort of pay attention to. And then there are, our continuing racial disparities in our community with getting these therapies, despite them being an oral pill. So, you'd think that would improve, but it really hasn't actually. So, cool. I don't think we have time for the case scenario. Or does you guys want it? Or yeah, let's just go with, yeah. Great. Okay. Awesome. Yeah.
Any questions for Erin?
There can't be. I answered everything. No, not actually. No, I don't.
Institution or
Not
elsewhere?
at our, no, no, I don't. I was thinking of the one we thought about. We thought about doing, and then we just ended up going to allo transplant. He has a unique DLBCL and CLL that without Richter's, that, yeah, he was a complicated case, but no.
Thanks, Erin.
Yeah.
All right, one thing I wanted to mention in regard to Erin's talk, so that talk was provided by the Iridium Continuing Education and Global Education Group. Apologize, I didn't mention that before the talk. And was also supported by an independent educational grant from Janssen and AbbVie. So anyway, thanks everybody for being here for the blood cancer boot camp. We really look forward to seeing you again next year. Thank you to all of our exhibitors for being here and supporting the blood cancer boot camp. Also, thank you to our administrative team, especially Rachel Anderson, who is standing back here with us now. And again, we couldn't have done it without Rachel and the entire administrative team. So thank you very much. And again, I think last but not least, our speakers. Thank you very much. This again was a program that was put together by our APP team. We're providing world-class care here at the University of Colorado. And, such a huge component of our team is our APP group. And we really appreciate you guys. I know these talks are not, easy to put together. It takes a lot of work, a lot of dedication, a lot of time. And it's really a reflection of how you are and how you practice as providers. And so we really appreciate all that you guys do, not only to put together talks like this, but to take really great care of our patients. So again, thanks everybody for being here, and we hope to see you next year at the 2025 Blood Cancer Boot Camp.